What do we call it when people have chronically high blood pressure? Typically 140 over, what is it, 140 over 100? Is that?
It's going to be high hypertension.
Hypertension. That's what I'm looking for. Now there's also what's called pre-hypertension. And I forget the actual clinical numbers on that. But pre-hypertension is what people kind of, doctors will start to see before they get into true hypertension, where their blood pressure is too high. And the interesting thing that happens slowly over time with people with hypertension is that these baroreceptors reset themselves. They have a set point. They know how much stretch is supposed to be exerted on these vessel walls. But over time, this hypertension causes these baroreceptors to reset, and they have a new set point, which is higher. Now, during exercise, that set point kind of goes out the window. But anyway, people with hypertension, those baroreceptors reset themselves. Now, I want to talk briefly about some of the treatments for hypertension because the different treatments relate to some of these different variables. And then I'm going to show you a hormone and enzyme pathway that plays a big role in blood pressure. All right, so let's say someone has high blood pressure due to very high cardiac output. One of the things that people can be given is something called beta blockers. Beta blockers work to decrease the heart rate. Sometimes people have an overstimulated sympathetic nervous system, and so there's a lot more sympathetic stimuli going to that SA node, keeping that heart rate very high. And we know that when heart rate's high, cardiac output is high, and that means blood pressure goes up, right? Think of cause and effect. If we can block the receptors that the SA node uses to tell block the receptors that the SA node responds to as far as increasing the heart rate, then we can lower the heart rate. And those receptors are actually called beta receptors, and these beta blockers will block those receptors and cause a decrease in the heart rate, which then, when heart rate goes down, blood pressure should go down as well, because we're decreasing cardiac output, and cardiac output is factored into blood pressure. So beta blockers is one mechanism, and that affects cardiac output. Now, if there's issues with blood volume, the amount of water in the blood, people can be given diuretics, which increase the amount of water in your urine. And there's different diuretics that affect different parts of the nephron. Some affect the collecting duct, some might affect the nephron loop. So these would actually decrease blood volume. Actually, they decrease blood volume by preventing water from getting reabsorbed back into the blood. We're going to start talking about the urinary system on Wednesday. And what we'll find is that we get a lot of water and ions, electrolytes, nutrients that are filtered out of that glomerulus. A significant amount of water. The majority of that water gets reabsorbed. We don't urinate out nearly as much water as our bodies filter in 24 hours. So the majority of that gets reabsorbed. So diuretics will affect the amount of water that's reabsorbed by the kidneys. And if there's less water reabsorbed, more water goes in the urine, and as a result of less water being reabsorbed, our blood volume decreases, and therefore blood pressure will decrease as well. There's also things called calcium channel blockers. And these affect peripheral resistance, in other words, constriction and dilation, or the friction that results from constriction and dilation. One of the things that we learned when we talked about skeletal muscle is that we need calcium for skeletal muscle contraction, right? Calcium binds to the troponin, causes the tropomyosin to move out of the way, and then That allows the cross bridges to start cycling and the actin heads, and the myosin heads to attach to the actin, right? So that calcium for skeletal muscle contraction comes from within the cell. Same with cardiac. 90% of the calcium for cardiac muscle contraction comes from within the cell. With smooth muscle, the calcium for smooth muscle contraction has to come from outside the cell. If we can block the channels that allow the calcium to move into the smooth muscle, then we can have an effect on how much those smooth muscle cells are contracting and affecting the diameter of those vessels. So calcium channel blockers will decrease the amount of constriction that's happening. If we're decreasing the amount of vasoconstriction, we're not necessarily vasodilating, we're just preventing those vessels from constricting. If we can decrease the amount of vasoconstriction that occurs, then we can decrease the blood pressure. Now there is another blood pressure treatment that can have an effect on, that does have an effect on peripheral resistance and blood volume. And this is called what's called the renin-angiotensin system. What happens is that there is, I guess we could call it a hormone, called angiotensin 2. Now, this is the end product of a series of reactions. But angiotensin 2 does several things. Number one, it stimulates the release of aldosterone. Remember aldosterone from chapter 17? It's a hormone released by the adrenal medulla, the zona glomerulosa. Aldosterone increases sodium reabsorption from the nephron. As a result of more sodium being reabsorbed from the nephron and not being in your urine, this results in increased water reabsorption as well. So more water is going back into your blood than would be in your urine. And as a result, this leads to an increase in blood pressure. Now this is one of the normal day-to-day mechanisms that's used by the body to regulate blood pressure and regulate blood volume. In order for us to maintain proper volume of water in our blood, aldosterone plays a role in that. But it also affects blood pressure. Okay? So increasing aldosterone increases blood pressure because more water is reabsorbed from the kidneys. That's one thing. That's how angiotensin affects blood. One of the ways angiotensin affects blood volume. The other thing angiotensin 2 does is it's a pretty powerful vasoconstrictor. And so angiotensin 2 causes widespread vasoconstriction pretty much throughout the body. And what do we know what happens when we have vasoconstriction? We get increased resistance, which means we get increased blood pressure. So angiotensin does that as well. And the third thing that angiotensin 2 does is it stimulates the release of antidiuretic hormone. So ADH, we know, is secreted from the posterior pituitary, but it's actually made in the hypothalamus, right? And this actually causes increased reabsorption of water from the collecting duct. Remember the collecting duct of the kidney? So as that water is traveling through the collecting duct on its way to the renal calyces, on its way to the renal pelvis, which then goes down the ureters into the urinary bladder, Okay? ADH causes some of that water to get pulled out of that urine at that point and get reabsorbed back in the blood. No, you're not reabsorbing pee into your body. You're taking the water out of that urine. Everything else stays in there. Taking the water out, that gets put back into the blood. So, putting water back into the blood, what's that doing to blood volume? Increasing it. And what does increasing blood volume do to blood pressure? Increases. So, angiotensin II does all of these. Now, if somebody has high blood pressure, some of that high blood pressure may be caused by increased water reabsorption, and maybe a diuretic isn't going to help that. Maybe someone has too much angiotensin II. That's why they have such a higher volume of water in their blood. So, what happens is that angiotensin II comes from a precursor called angiotensin I. And angiotensin I comes from something called angiotensinogen, which I'm not sure if I mentioned when we talked about hormones or not, is coming from the liver. Angiotensinogen is a protein that comes from the liver. It's kind of an inactive protein. It doesn't do anything. Well, the enzyme renin, which comes from the kidneys, converts that angiotensinogen to angiotensin II. It actually almost cuts it in half. Takes off a significant number of those amino acids. Then there's another enzyme, ACE, angiotensin converting enzyme. Angiotensin converting enzyme converts angiotensin I to the angiotensin II, and then angiotensin II stimulates all these things to happen. Now, all these things happen normally in our body to help with our day-to-day maintenance of blood volume and blood pressure. Mainly for maintaining blood volume, but there is a relationship, as we know, between blood volume and blood pressure. So if somebody has a lot of issues affecting their blood pressure, there might be a way to treat them by inhibiting all these processes at once. And that's where ACE inhibitors come in. Lansoprazole, someone mentioned earlier today, is an ACE inhibitor. This drug will block the action of angiotensin-converting enzyme. If we block angiotensin-converting enzyme, then we don't get angiotensin I, we don't get the increased release of aldosterone. You're still going to get some. You're not going to have the widespread vasoconstriction like you would, and you're going to decrease the amount of ADH. If we decrease the volume of aldosterone, we decrease the amount of water reabsorption, which means we decrease the blood volume, which means that blood pressure should go down. We decrease the widespread vasoconstriction, blood pressure should go down. We decrease the amount of water reabsorbed from the collecting duct, which means that we decrease blood volume, which means that we decrease blood pressure.